And now we move to the second topic that you already commented, namely the point-of-care manufacturing of the CAR T-cell. It's a pleasure to introduce Professor Carlos Fernández de Larrea from Barcelona. And as I mentioned before, the Barcelona group made an outstanding effort for promoting the academic trials in the different hematological malignancies. And today's Carlos will address the issue of academic model for CAR T-cell development in multiple myeloma clinical results with the RE002H and future plans. Please.
Good afternoon. Thank you so much. Thank you so much, Professore, for the kind introduction. And thank you to Milten for the invitation to participate in this so interesting symposium. And I'm going to talk about our academic model, now focus on multiple myeloma. Here you can see my disclosures. We know that we have several CAR T-cells with impressive efficacy and safety in multiple myeloma, but they are still expensive. They are autologous products with on-demand manufacturing with difficulties in product distribution with large vein-to-vein times. And we still need a strategy of optimization, such as off-shelf products, allogeneic or in vivo CAR T, but they are still under development. With all that, the access to CAR T therapy remains challenging, and at the end, around the world, only a small fraction of eligible patients finally receive this treatment. As an example from last year from my colleague, Julio Delgado, you can see that even in Europe, where there are several approved CAR T-cell for myeloma, even there are some changes in the last year, the real access with reimbursement in the majority of European countries is quite limited. The other point is that you have, when you are establishing your goal, when you are developing these academic strategies, because we are usually working with this scientific approach. When you get a grant and a paper, it's like Eurovision that you have 12 points, choose one. However, if you have a drug developer approach, that is not the goal. The goal is to get a marketing authorization with a product that can reach the real patients. Our first product was RE1, Barcel, CAR against CD19 that was developed as RE2H also in the Clinimax Prodigy system for the treatment of acute lymphoblastic leukemia and B-cell lymphomas. We got the price and reimbursement agreement with the Ministry of Health in Spain that was approved under the hospital exemption clause, and we also obtained the prime designation. A phase 2 trial is completed in Spain and was already presented, and a phase 2 also is in progress in Europe. But I'm going to focus on multiple myeloma. That is the second most frequent hematological malignancies. And we know that even we have improved significantly the results in the clinical practice in this disease. For the vast majority of patients, there is still an incurable disease with a very ominous prognosis when they are refractory to the main therapies until now. We have 2 approved CAR T-cells for clinical use in Europe, ide-cel and cilta-cel. I'm going to focus in RE2H, cel. is a CAR that was developed, all the preclinical research in our institution, in vitro and in vivo, showing that humanized CAR T cell was a second generation humanized scFv with a 4-1BB costimulatory molecule was effective when treating mice. And we started a clinical trial in Spain. We produced the lentivirus in Barcelona. 2 centers in Pamplona and Barcelona produced CAR T cells, and 7 centers around the Spanish geography were able to treat the patients and follow with them. Some characteristics of the trial was a lentiviral transduced autologous T cells. Following the experience with SARI-21, we fractioned the first infusion of 3 million of CAR T cells in 10, 30, and 60% of the first dose. And we incorporated also a second dose as a booster after 3 months of the first infusion in patients with some degree of response, non-progressive disease, and non-limiting toxicity. This is characteristic of the 60 patients. A median age of 58 years, a median number of prior lines of 3, and a population enriched for high-risk features such as plasmacytomas, high-risk cytogenetics, and exposure to the main drugs. The main result of efficacy, we were able to see a 95% of overall response with almost 60% of complete response. That was also translated into 98% and 96% of negative measurable residual disease in the bone marrow by next-generation flow centralized in Pamplona. After a median follow-up of 24 months, the median progression-free survival was 20 months, with an median overall survival that was not reached, and an overall survival rate at 24 months of 63%. We had no patient became BCMA negative in this study. However, it was a significant reduction in the BCMA expression in plasma cell when compared the time of progress with the time of the screening. We recently also evaluated the impact of extramedullary disease. As with other groups, we have demonstrated that the true extramedullary disease is associated with shorter progression-free survival and shorter overall survival, and that also the metabolic tumor volume by PET-CT at the screening is a very important tool for selecting patients with poor prognosis. About the second dose, the booster, it was feasible. 80% of the patients eligible received the booster dose after a median time of 4 months. 1/3 of the patients received a second lymphodepletion according to the persistence in peripheral blood with no side effects after this booster dose administration. In fact, in our hospital and other hospitals, this dose is now administered in the outpatient clinic. The response was evaluable in 42 patients, and in 11 of them, we were able to see an improvement of the response. The majority of them is very difficult to establish because they were already in a stringent complete response. About safety, the majority of patients developed a cytokine release syndrome, but it was mainly grade 1 or 2, and it was the main reason for the administration of tocilizumab. 13 patients did not receive the third faction due to CRS. However, the efficacy was the same. And one of the characteristics of this protocol is the low neurotoxicity, with only 2 patients with grade 1 ICANS and no late neurological events. Beyond this trial, we have treated, now I can update, is 190 patients have been successfully treated with this point-of-care approach. After the clinical trial, we started a compassionate use program in Spain with around 90,000 euros per patient, and an academic European trial with this point of care strategy is currently under design. We have also a very positive impact in the Spanish and Catalan society, and particularly when we got the national hospital exemption approval last year for patients with relapsed refractory multiple myeloma, at least after 2 prior lines of treatment, exposed to the main 3 families of drugs, and with disease progression to the last line of treatment. We have treated also a patient. It was the first patient treated with RE2H. It was a patient with AL amyloidosis with renal involvement, and I'm very lucky that she's still in my outpatient clinic in complete response after 5 years with organ response. That was mainly kidney involvement. We have treated mainly no patients in very advanced phase, and the idea in general with CAR T-cell myeloma is to get this treatment earlier as a consolidation or even as part of the first line of treatment. And in this sense, we have focused in the most aggressive monoclonal gammopathy, that is the plasma cell leukemia with a new definition. And we are going to start next month a clinical trial in Spain with including RE2H as part of the first line of treatment for patients with plasma cell leukemia. These academic approaches are also a very interesting platform for developing a next generation of CAR T cells, using some strategies to improve the persistence or also to avoid the negative or low antigen relapses, using, for example, a bispecific CAR T cells, and also for correlative studies, for example, for using the PET-CT or the mass spectrometry for monitoring the disease, for other factors related to the prognosis, such as CAR density, good microbiota, the impact of the minimal residual disease, and also to analyze the impact of this point of care, for example, reducing the vein-to-vein times and the comparison between manufacturing sites and also between administration centers. And with that, we are trying to improve the access to CAR T-cell therapy with these academic point-of-care manufacturing strategies. I would like to thank all the agencies that have collaborated with this strategy, to all our patients and families, to all the centers that have participated in Spain, and to all our group in the Hospital Clinic, Universitat de Barcelona, that have collaborated to create this group to treat our patients with multiple myeloma. And thank you so much for your attention.